Imagine a patient survives a grueling 6-hour procedure. The operation is totally flawless. The anastomosis is pristine. The margins are clear. But, simply because their calf rested at a slightly awkward angle on the operating table, a microscopic cascade gets triggered in a deep vein.
Right, and then 3 days later, that microscopic event kills them via a massive pulmonary embolism. It's wild.
It really is. The microscopic dictates the macroscopic. So today, we are diving deep into that unseen battlefield of vascular pathology.
It is basically the ultimate surgical irony, isn't it? I mean, we spend years learning how to control massive hemorrhage and clamp major arteries, but the pathology that often kills our patients is this silent, completely invisible mechanism happening right inside the vessel wall.
Literally turning the blood itself into a weapon. And if you are a surgical resident preparing for the MRCS exam, you absolutely have to master this unseen battlefield. There is just no getting around it.
Definitely. It's foundational.
So before we jump into today's rapid fire session, head over to medsynclimited.com/Anki and grab the MRCS Accelerator NKI deck.
Yeah, it's an indispensable resource for this specific kind of high-yield revision.
It really is. It contains over 2,400 questions across 23 themes, and that includes 15 subspecialty topics designed specifically to help you rapidly recall the exact, commonly tested facts we are going to be breaking down today.
Highly recommend picking that up.
All right, our mission today is straight to the point. We're breaking down the pathophysiology and clinical presentations of thrombosis, embolism, ischemia, and gangrene, and we are doing this in a strict question and explanation interview style. Let's start right at the foundation.
Sounds good to me.
So on the wards, attendings use thrombus and clot interchangeably all the time, but for the exam, they are not the same thing, are they?
Oh, definitely not. The examiners will absolutely catch you out on this if you blur the lines.
Yeah.
A thrombus is defined very specifically.
As a solid mass formed in the living circulation, right?
Exactly, from the components of the streaming blood. The biological imperative here is streaming blood. It's an active dynamic process that requires the constant delivery of fresh platelets and fibrinogen that only flowing blood can provide.
So it is essentially an active rebellion of the living system. It literally requires flow to build itself, which means a clot is something else entirely.
Yeah, a clot is simply the solidification of blood when it is static. It happens when blood pools outside a vessel, or when you draw it into a test tube.
Well, when it coagulates within the vessels of a dead body.
Right. Spot on. There is no flow, there's no dynamic layering, it just gels.
Okay, so if a thrombus is this dynamic living system problem, we have to look at what triggers that system to rebel. This always brings us back to Virchow's triad.
Ah, yes, the classic triad.
But I want to push back a bit on how it's taught. The triad is changes in the vessel wall, changes in blood flow, and changes in the blood constituents. But when I look at arterial thrombosis versus venous thrombosis, they don't seem to trigger the triad equally.
That is a really astute observation.
It feels like different vessels care about entirely different things.
You've hit on a major testing point there. They have very different primary drivers because of their hemodynamic environments. Arterial thrombosis is overwhelmingly driven by that first pillar, which is damage to the vessel wall.
Because arteries are high-pressure, high-velocity systems.
Exactly. Stasis isn't really an issue because the blood is moving too fast. To get a thrombus to form in an artery, you need a physical defect to give platelets something to latch onto.
Like a snag in the river.
Right. Atherosclerosis is the classic culprit here. It damages the protective endothelium of the coronaries, the abdominal aorta, or the mesenteric arteries.
Exposing the underlying collagen and triggering the cascade. The high pressure washes everything away unless there's a physical snag in the wall. That makes sense. So venous thrombosis is the opposite.
Precisely opposite. Venous thrombosis is primarily driven by the second pillar.
Which is alterations in blood flow.
Specifically stasis, yeah. Veins are a low-pressure capacitance system. The blood is already moving slowly. If a patient is immobilized after a major pelvic trauma, or they're in heart failure.
Or even just experiencing mechanical pressure on the calf veins from the operating table.
Right, the blood flow slows to a crawl. This stasis prevents the liver from clearing activated clotting factors, and they accumulate locally until a thrombus initiates, even if the vessel wall is perfectly healthy.
Let's zoom in on that initiation. Once the triad is triggered, how does this mass actually construct itself? It's not just a random clump of cells, is it?
No, it's actually highly structured architecture. The initial event is platelets adhering directly to the exposed, damaged endothelium.
And once they stick, they degranulate, which calls in more platelets.
Forming a really dense aggregate, yeah. But the flowing blood doesn't stop. It washes over this platelet plug, and a layer of fibrin and trapped leukocytes deposits right on top of it.
So you have a platelet base, then a fibrin leukocyte blanket, and because the blood keeps flowing, this process just repeats itself.
It repeats in alternating waves. You get a secondary layer of platelets collecting on the surface of that fibrin clot, followed by another layer of fibrin and red cells.
Ah, and this gradual extension leads to a propagated thrombus.
Exactly.
You know, the texts always mention the lines of Zahn as the morphological hallmark of this process. The way I finally understood this was thinking about fluid
I
dynamics.
love this analogy.
Right, because the platelets aggressively stick during periods of higher flow, and the softer fibrin and red cells settle during micro periods of slower flow. You get these alternating lamellar layers.
And because those different materials contract at different rates as the mass organizes, the surface gets these distinct ridges.
It looks exactly like the rippled sand on a beach after the tide goes out.
Yeah, and that rippled appearance is the definitive proof on autopsy that a mass formed in flowing blood and wasn't just a post-mortem clot.
So we have this rippled, layered mass anchored to the vessel wall. But it can't just sit there forever. What is the ultimate fate of this structure?
The body has four ways of dealing with it. The best case scenario is lysis.
Where the endogenous plasminogen system successfully dissolves the thrombus completely.
Right. The second is recanalization, which is this fascinating biological salvage operation. Macrophages essentially eat out the center of the organized thrombus, and endothelial cells migrate in to line these new microtunnels.
Restoring some degree of blood flow straight through the mass, nature literally boring a tunnel through the roadblock. What are the other two fates?
The third is propagation. The thrombus itself acts as a physical obstruction, worsening the local stasis.
Which causes more thrombosis to build on its tail, extending its length indefinitely.
Yep. And the fourth, which is the one we fear the most in surgery, is embolization. The anchor fails. Part or all of the thrombus breaks loose, travels downstream, and wedges into a vessel too small for it to pass.
Which brings us to the nightmare scenario. When that anchor fails, where the embolus originates entirely dictates what kind of catastrophe you are about to face. Let's trace the anatomy. Walk through the distinct pathways of venous versus arterial thromboemboli.
Let's do it. If we start with venous thromboembolism, the vast majority originate in the deep veins of the calf or pelvis. Once that mass breaks free, it becomes a projectile traveling up the inferior vena cava.
It passes into the right atrium, through the tricuspid valve into the right ventricle, and gets pumped straight into the pulmonary arterial tree.
The classic PE.
Right, the pulmonary embolism. But the clinical presentation varies wildly, doesn't it? From a patient feeling a bit winded to sudden cardiac arrest.
It totally depends on the caliber of the pulmonary vessel that gets obstructed. Small emboli might just cause asymptomatic showers. Medium emboli include segmental arteries causing sharp, pleuritic chest pain and dyspnea.
And a massive saddle embolus can wedge at the bifurcation of the main pulmonary trunk, blocking both lungs simultaneously.
Causing instantaneous right heart failure and death. But here's the truly fascinating part. Sometimes, even if only a single major pulmonary branch is blocked, the patient goes into profound shock.
This is due to a vagal reflex, right?
Yes. Stretch receptors in the blocked artery trigger a massive autonomic misfire, causing intense spasm of the remaining pulmonary arteries and even the coronary arteries.
So the mechanical blockage is small, but the neurogenic reflex shuts the whole system down. A terrifying chain reaction.
Absolutely terrifying.
Now, an arterial embolus is a completely different trajectory because it's already in the systemic circuit.
Right. An arterial embolus usually originates in the left heart, so perhaps a mural thrombus following a myocardial infarction.
Or an auricular thrombus whipped up by the chaotic flow of atrial fibrillation.
Exactly. When it breaks loose, it leaves the left ventricle and has the entire systemic arterial tree as its target. It travels distally until the arteries taper down,
Eventually wedging in the brain, the mesenteric supply to the gut, or the arteries of the lower limb.
causing acute downstream infarction.
And the only crossover exception is the paradoxical embolus, right? Where a venous thrombus traveling to the right heart slips through a right-to-left shunt, like a patent form in Oval.
And it bypasses the lungs entirely to become a systemic arterial problem.
But we focus so much on blood thrombi. Thrombi are not the only things that can act as a projectile. What else can plug the plumbing?
The list is surprisingly long. Gas embolism is a major one. This happens if air is introduced into a vein, usually iatrogenically via an unprimed IV line or through trauma to the neck.
Because the venous pressure in the neck is lower than atmospheric pressure during inspiration.
Right, so a lacerated jugular vein will literally suck room air into the circulation, especially if the patient is sitting upright.
There's also nitrogen embolism, commonly known as decompression sickness. The bends. Let's dig into the physics of that for a second. It's all about solubility, isn't it?
It's pure physics. According to Henry's law, gas solubility in a liquid increases with pressure. When a diver is at depth, large amounts of nitrogen dissolve into their blood and tissues.
If they ascend too rapidly, the ambient pressure drops suddenly.
And the nitrogen comes out of solution, forming physical gas bubbles in the blood and within the tissues themselves. These bubbles occlude microcirculation and cause agonizing joint pain, causing the diver to bend double.
Wow. There is also amniotic fluid embolism, which is a rare but completely devastating obstetric emergency. How does fluid occlude a vessel?
Well, it occurs in about 1 in 50,000 deliveries when placental detachment allows amniotic fluid to breach the maternal circulation. But it's not a mechanical fluid plug.
Oh, really?
Amniotic fluid is packed with thromboplastins, which are potent tissue factors. When they enter the mother's blood, it is like throwing a match into a fireworks factory. They trigger a massive, uncontrolled systemic coagulation cascade.
So the mother develops severe respiratory distress, shock, and ultimately goes into DIC.
Exactly. Disseminated intravascular coagulation consuming all her clotting factors and leading out.
Okay, let me challenge something that always felt poorly explained in medical school, which is fat emboli. The classic exam scenario is a patient with a fractured femur who suddenly crashes a day later. I was always taught it was just blobs of marrow fat getting physically squeezed into the ruptured veins and plugging the pulmonary capillaries. Is it really just a mechanical fat plug?
The mechanical theory is outdated, and it's a trap for the unwary resident.
Really?
Yeah. While we can demonstrate microscopic fat globules in the lungs of 90% of patients with multiple fractures, clinically significant fat embolism syndrome is relatively rare. The severe symptoms, the fever, respiratory distress, cerebral coma, and those classic petechial skin rashes are driven by a biochemical cascade, not a physical plug.
So what is the biochemistry then?
The fat macroglobules that enter the circulation are broken down by lipases into toxic free fatty acids. These fatty acids cause severe chemical injury to the endothelium of the capillaries in the lungs, brain, and skin,
Which triggers a massive inflammatory response.
stripping the endothelial lining, causing the tiny hemorrhages we see as petechiae, and leading to acute respiratory distress syndrome. It's a metabolic firestorm, not a physical quirk.
A crucial distinction. So whether it is a piece of ruptured atheroma, a nitrogen bubble, or a storm of free fatty acids, when an obstruction occurs, the downstream tissue starves. This leads us directly into vascular insufficiency and infarction. But emboli aren't the only causes of a starvation state. What are the non-embolic mechanisms of vascular insufficiency?
We see progressive occlusion from atheroma, where the plaque simply grows until it chokes the lumen. We see torsion, where a mobile organ like the testes or a loop of bowel twists on its vascular pedicle, strangulating its own supply.
We see external compression from expanding tumors, or even a tight plaster cast crushing an artery against a bone.
Yep, we see intense spontaneous vascular spasm, like in severe Raynaud's disease. And then we have hemodynamic shifts, like Steele syndrome.
I want to focus on Steele syndrome, because the mechanics are fascinating. The best way I've come to understand it is to think of the arterial system like a highway network. Normally, blood travels down the main highway of the arm and takes the smaller, high-resistance local roads to supply the hand.
That's a good way to look at it.
But if we surgically create an arteriovenous fistula at the elbow for dialysis, we essentially build a massive zero-resistance superhighway that dumps arterial blood directly into the venous return. Fluid dynamics dictate that blood will always take the path of least resistance.
So the blood bypasses the high-resistance local roads entirely.
Exactly. The hand starves not because there is a blockage, but because the traffic took the faster bypass route. It steals the flow.
That is a brilliant way to conceptualize it. It is entirely about pressure gradients and resistance.
Now, if a tissue is subjected to ischemia, whether from a steal, a spasm, or a clot, what factors determine if that tissue manages to survive on life support, or if it crosses the threshold into frank infarction and tissue death?
Survival depends on 4 major variables. First is the speed of onset. A slow-growing atheroma allows the body months to grow alternative collateral vessels.
A sudden embolus provides zero time to adapt, causing massive necrosis.
Right. Second is the physical extent of the obstruction. Third is the anatomical reality of the collateral circulation. Some organs just don't have backup vessels.
And fourth is the metabolic demand of the specific tissue. The brain requires immense constant oxygen and will infarct within roughly 4 minutes of complete ischemia.
While skeletal muscle can tolerate a tourniquet for a couple of hours.
The MRCS loves to test the macroscopic appearance of these infarcts, specifically the distinction between red and white infarcts. Break down the vascular architecture that causes this.
It comes entirely down to whether the organ is a solid dead end or a spongy tissue with a backup supply. White or pale infarcts occur in solid organs supplied by end arteries. The heart, the spleen, and the kidneys are prime examples.
So when the solitary supplying artery is blocked, the tissue dies.
Because it is a dense, solid organ with no alternative blood supply, blood cannot seep back into the necrotic area, so it remains pale and bloodless.
And red infarcts.
Red or hemorrhagic infarcts occur in loose, spongy tissues that possess a dual blood supply. The lungs and the liver are classic examples. If a pulmonary embolism blocks a branch of the pulmonary artery, the downstream lung tissue infarcts and dies.
However, the lungs are also supplied by the bronchial arteries from the systemic circulation.
Right. This secondary flow isn't sufficient to keep the tissue alive, but it continues to pump blood into that loose, dying, necrotic scaffolding. The dead tissue becomes engorged with hemorrhage, appearing dark red.
That makes perfect mechanical sense. Now, what if there is no physical blockage at all? Can a patient suffer an infarct with completely open pipes?
Absolutely, through what we call low-flow infarction. Think of it like a sprinkler system. If the water pressure drops low enough, the sprinklers at the very end of the line just won't get any water, even if the pipes are totally clear.
Ugh. So in the body, we have these vulnerable watershed territories that sit at the extreme distal boundaries between two major arterial supplies.
The splenic flexure of the colon is the classic example, sitting right between the superior and inferior mesenteric artery territories. If a patient suffers profound systemic hypotension, say from septic shock or cardiac arrest, the perfusion pressure plummets.
Those distant watershed areas simply don't receive enough flow to meet their metabolic needs, and they infarct purely from low pressure.
Exactly.
This brings us to the ultimate consequence. The absolute endpoint of severe, untreated peripheral infarction is gangrene. For the clinical exams, how do we biologically differentiate dry gangrene from wet gangrene?
Dry gangrene is a sterile, gradual process resulting from chronic ischemia. The tissue slowly dies, mummifies, and turns black. Crucially, a clear line of demarcation forms between the dead tissue and the adjacent viable tissue.
Left alone, the dead portion will eventually auto-amputate, which we often see in chronic diabetic toe ischemia.
Wet gangrene, however, is a biological race against time. It occurs when ischemic tissue becomes infected with putrefying bacteria.
The necrosis is liquefactive, spreading rapidly proximally with absolutely no line of demarcation.
If you do not perform an urgent, high proximal amputation, the bacteria and their toxins will flood the systemic circulation, and the patient will rapidly die from overwhelming sepsis.
Let's put all of this physiological theory into practice. I'm going to fire 3 clinical scenarios at you, straight from the MRCS OSCE playbook. Break down the clinical reasoning for each. Ready?
Let's do it.
Scenario 1. A 42-year-old female, 5 days post-mastectomy and DIEP flap reconstruction, develops a swollen, painful calf. Her vitals are stable, but a duplex Doppler shows a solid, non-compressible mass in the popliteal vein.
This is a deep vein thrombosis. We are looking at Virchow's triad firing on all cylinders here. She has vessel wall injury globally from a massive surgical insult. She has profound venous stasis from being paralyzed on an operating table for 8 hours, followed by ward bed rest.
And she has a systemic hypercoagulable state simply by virtue of having a malignancy and being post-operative.
Exactly. You can't just memorize the triad. You have to see how the hospital environment causes it.
Scenario 2. A 69-year-old male with a known history of claudication. He gets cramp-like calf pain after walking 2 blocks. He suddenly presents to the emergency department with acute, agonizing left leg pain, severe pallor, and a complete loss of sensation below the knee.
The diagnosis here is acute on chronic arterial ischemia. The history of claudication is the giveaway. It tells us he has a baseline of severe chronic atherosclerosis. The sudden catastrophic change means the fragile fibrous cap of one of those atheromatous plaques has ruptured.
That ruptured plaque exposed highly thrombogenic collagen to the high-velocity arterial blood,
Instantly initiating a propagated thrombus that completely choked off the remaining lumen. The leg is now dying.
the chronic setup creating the acute disaster. Final scenario, scenario 3. A 60-year-old male in the ICU. 2 days ago, he suffered a cardiac arrest and received 45 minutes of CPR before return of spontaneous circulation. Today, his lactate is climbing rapidly. He has a profound metabolic acidosis, but crucially, his abdomen is soft and his abdominal X-ray is totally normal with no dilated loops.
The trap here is the normal X-ray. This is a classic presentation of low-flow mesenteric ischemia. During those 45 minutes of CPR, his systemic perfusion was a fraction of normal. The watershed areas of his bowel, like the splenic flexure, were starved of oxygen and infarcted without any physical clot being present.
So the reason the X-ray is normal is that mucosal necrosis happens long before transmural necrosis.
Exactly. The inside lining of the gut is dead and leaking lactate, causing the acidosis. But the muscular wall hasn't perforated or lost its tone yet. If you wait for the X-ray to show dilated, perforated bowel, the patient is already unsalvageable.
That is the exact level of clinical synthesis you need to survive the boards. We've covered the entire journey from a microscopic platelet plug to systemic gangrene.
It really emphasizes that the most dangerous things in surgery are often the mechanisms you cannot clamp.
Which is exactly why you need to build up your physical skills alongside this theoretical knowledge. If you are gearing up for the exam, head straight over to medsynclimited.com to get their surgical simulation kit.
It includes a comprehensive suturing kit, microsurgery instruments, and more, allowing you to build that vital muscle memory right at home.
Reading about an anastomosis is one thing, but feeling the tension on the needle is another entirely.
That's absolutely true.
If you found this deep dive valuable for your revision, please hit follow on the show so you don't miss our upcoming rapid-fire episodes. Rate us if you learned something today.
And definitely drop a comment or question below about the vascular pathology we covered.
We'd love to hear what specific topics or OSCE stations you want us to tackle next. Keep studying that unseen battlefield, and we will see you on the next deep dive.